Hello, can everyone hear me?
Yes,
Hi, everyone.
that's
Oh,
good now.
awesome. Okay. Hi, everyone. Welcome to the first session in our Mind the Bleep UK MLA webinar series on gastroenterology. My name is Rachel. I'm currently an F2 doctor, and this is Olivia. She's also one of the F2 doctors. I'll let her introduce herself, but we're both the... Yes, we can hear you.
Cool. Yes, we're both the gastroenterology specialties for Mind the Bleep. And today we're going to be doing lower GI disease and bowel pathology. And hopefully it'll be quite high yield. We've got some questions and then we'll do a bit of teaching in between as well.
Okay. So there's a lot of things for us to cover in terms of lower GI. We've got lots of other sessions planned to cover other gastro things, but today we're going to be focusing on inflammatory bowel disease, irritable bowel syndrome, red flag bowel symptoms, celiac disease, gastroenteritis, nutritional deficiencies, and of course, lots of SBAs in between. First of all, starting with inflammatory bowel disease. And just to kick things off, we've got some SBAs. So feel free to write them in the chat, or if you're feeling shy, just have a think, and I'll give everyone about a minute or so to have a read through. So the first question is, we've got a 19-year-old woman who presents with a 6-month history of intermittent diarrhea and abdominal pain. She has no weight loss and no nocturnal symptoms. Examination is normal, and blood test shows normal CRP and hemoglobin. Which investigation Okay, so if we break down this question, the correct answer is fecal calprotectin. The main reason is because fecal calprotectin is the first line investigation when we are suspecting conditions like inflammatory bowel disease. Abdominal ultrasounds and colonoscopies. A colonoscopy would be the next step if the fecal calprotectin came back positive. Abdominal ultrasound, stool cultures, and CT abdomen are not as helpful at this point, and they're not commonly used in terms of investigating inflammatory bowel disease, but they may be useful for considering other bowel pathologies. I'm sorry, these seem to all be giving away the answer before we've got them. Okay, question 2. We've got a 34-year-old man with Crohn's disease, presents with painful red nodules over the shins. He reports a recent flare of his bowel symptoms. An examination reveals erythematous subcutaneous nodules on both lower legs. What do you think is the most likely diagnosis? So the correct answer is erythema nodosum. If you look at these images that we've got here, these are the 5 conditions that we've described. So the first one on the top left is pyoderma gangrenosum. That is also commonly affected with inflammatory bowel disease, but that tends to look different from erythema nodosum. Pyoderma gangrenosum is more of an ulcerated appearance, whereas erythema nodosum is those sort of classical painful red nodules. And that's what we see here in the top right-hand section. Erythema nodosum is associated with other conditions as well, so it's not specific for inflammatory bowel disease, but it is one of those skin conditions and clinical signs that you can see, particularly in active inflammatory bowel disease. Option C, which is dermatitis herpetiformis, is the bottom left image, and that's classically seen in celiac disease. Option D, necrobiosis lipoidica, is a skin condition that's sometimes associated with diabetes, hence the name lipoidica, and that's what we see on the bottom middle slide. And then option E, cellulitis, that's as we all know, infection of the skin, and that is the bottom right slide that we see. Okay, so what is inflammatory bowel disease? We need to, before we sort of go into how we treat it, we need to know how we define it. And it is defined as a chronic idiopathic condition that relapses and remits. So patients will come between will often have flare-ups and then have periods of remission of the disease. And essentially what it is inflammation of the GI tract. The two main types to be aware of are Crohn's disease and ulcerative colitis. And in terms of the symptoms to be aware of, we've got diarrhea, abdominal pain. Oftentimes there's PR bleeding and mucus in the stool. Patients may be complaining of systemic symptoms as well, like fatigue, weight loss, and compared to inflammatory irritable bowel syndrome, the symptoms are typically nocturnal. So what that means is that patients may be waking up even overnight to open their bowels, compared to something like IBS, where patients are less likely to have nocturnal symptoms, and also extraintestinal manifestations, which we'll go into. So, first of all, let's look into Crohn's disease. Crohn's disease most commonly presents in a bimodal distribution. So patients classically present between the ages of 15 or 35, or they present later in life between 55 and 70. And you've got classic symptoms of abdominal pain, commonly in the right iliac fossa, and non-bloody diarrhea. If we look at what you would see under a microscope, that's that bottom left image, you'll see what we classically describe as a non-caseating granuloma, as you can see with the arrow. You've got lymphoid hyperplasia, so hyperplasia of the lymphoid tissue, and transmural inflammation, which means it's affecting all layers of the bowel mucosa. And then in terms of the macroscopic findings, which you can see in the top right, this is what you would see on endoscopy. Commonly, you might see aphthous ulcers or mouth ulcers within the oral ulcers. And within the endoscopy itself, you'll have cobblestone appearance on microscopy. Crohn's disease affects all layers of the bowel, and it can affect anywhere from the mouth to the anus, although it most commonly affects the terminal ileum. So it can, that's why you can have lesions from your mouth all the way to your anus. But it is classically characterized by skip lesions. So you'll have some areas of disease in the bowel, in the GI tract, some areas of normal bowel, and then further areas of disease. Just bear with us one moment. I'm just trying to change the slide so that we can hopefully get the answers hidden for everyone. Sorry, just bear with us while this is loading. Okay, what we'll do is, whilst we're just waiting for the other presentation to load, I'll just move on, and then once that's ready, we can try and see if that works with the SBAs. Okay, try again. Okay, so how do we manage Crohn's disease? Now, the management is different depending on if the patient is in an active flare-up or if we're just trying to keep them in remission. In terms of managing active flares, smoking cessation we know helps. What we typically try is monotherapy, first of all, with something like glucocorticoids or budesonide. You can also try 5-aminosalicylates, things like sulfasalazine or mesalazine, but they aren't as effective. And then if patients are having multiple exacerbations within a year, then we would consider things like thiopurines, methotrexate, and biologics. In terms of maintaining remission, once the patient has been treated for the flare, the first line is medications like azathioprine and mercaptopurine, and the second line medication would be medications like methotrexate. Eventually, around 80% of patients with Crohn's disease will have to undergo surgery because of complications, which we'll get into. Ulcerative colitis is the other main type of inflammatory bowel disease, and similar to Crohn's disease, it has this bimodal distribution of presentation, so earlier in age from 15 to 35, or again later 55 to 70 years old. The way it differs from Crohn's disease in terms of its presentation, and this is something that you may also see in exam questions, is that the questions may often mention symptoms like bloody diarrhea, tenesmus, or urgency. And a key association in terms of extraintestinal manifestations is a condition called primary sclerosing cholangitis. This is essentially when you've got intrahepatic and extrahepatic sclerosis or thickening of the bile ducts, and it is associated with other conditions like cholangiocarcinoma. It's another type of autoimmune condition. In terms of what we find both microscopically and macroscopically in ulcerative colitis, so looking down the microscope, we'll see continuous inflammation, but it's only limited to the most superficial layers of the bowel mucosa, so the mucosal and submucosal layers, whereas Crohn's disease affects all layers and is transmural. Looking macroscopically, you'll have what we call crypt-like abscesses, neutrophil infiltration, and continuous inflammation compared to just inflammation that is affecting the skip lesions that we see in Crohn's disease. And sorry, there's an error there. It's ulcerative colitis isn't usually mouth to anus, so typically it affects the rectum and it can spread proximately, but typically is mainly limited to the rectum and large bowel. In terms of how we're classifying the severity of UC, it's classified by how often patients are opening their bowels, whether they've got blood in their stool, and systemic symptoms like if they're tachycardic, if they're pyrexic, if they're anemic, and looking at blood tests like the ESR level. Inducing and maintaining remission in ulcerative colitis is slightly different from Crohn's disease. So the first line for inducing remission in flare-ups for ulcerative colitis is 5-ASAs like mesalazine. This can be given topically if the disease is limited to just the rectum, or sometimes we may need to give them orally if the disease is more proximal. In cases of severe colitis, we need to admit patients into hospital and they need more intensive treatment with IV steroids, plus or minus cyclosporin, or even surgery in refractory cases. We can also, in very unwell patients, consider medications like biologics. So we've got medications like infliximab, ustekinumab, and vedolizumab. And also, of course, as I mentioned, surgery. In terms of maintaining remission for these patients, it's similar to inducing remission. We would also consider things like the topical and oral aminosalicylates. In severe relapses, you may need to consider azathioprine or mercaptopurine. And note that in ulcerative colitis, we don't recommend giving methotrexate, whereas in Crohn's disease, methotrexate is one of the options that we give for maintaining remission. So in terms of the extraintestinal manifestations in both UC and Crohn's disease, these are the different things that you might see. So first of all, you can get extraintestinal manifestation. Extraintestinal just means any sort of clinical signs of disease that aren't infecting the bowels. So you've got conditions like conjunctivitis, episcleritis, and iritis. You've got clubbing, as you can see here, which commonly causes spoon-shaped nails. You've got pyoderma gangrenosum and erythema nodosum, which we mentioned at the start. You can also get enteropathic arthritis and also an increased risk of bowel cancer in general because of the inflammation. Specifically looking at extraintestinal manifestations associated with the Crohn's disease and ulcerative colitis. So Crohn's disease is more commonly associated with perianal fistulas, perianal abscesses. Patients may have mouth ulcers and higher rates of malabsorption, whereas ulcerative colitis is more classically related to primary sclerosing cholangitis or toxic megacolon. And these are things that can often come up in SBAs. In terms of how we investigate a patient who we suspect we have inflammatory bowel disease, first of all, we break them down into blood tests, stool tests, and then further tests that we can do sometimes in the specialist setting. So blood tests, what you'd often see is in a full blood count, patients will be anemic, and specifically of microcytic anemia. During a flare-up of inflammatory bowel disease, patients will have raised inflammatory markers, and a common sort of overlap that we need to do is a celiac screen, which patients will be negative for. So oftentimes, because they can have overlapping symptoms, what we need to do is test for celiac disease as well so that we can rule it out. In terms of stool tests, classically with IBD, you'll have a raised calprotectin level. And if you're suspecting an infective cause, you may wish to do a microscopy, MCNS, that would come back negative. Now, if patients have a positive fecal calprotectin level, then the next steps are doing endoscopy, biopsy, and that is diagnostic of inflammatory bowel disease and can also help tell us the type of inflammatory bowel disease the patient's likely to have. And if we're concerned about any complications the patient may have, like toxic megacolon, primary sclerosing cholangitis, then you may consider further imaging like an X-ray, CT, MRI. So this is a nice table that summarizes the key differences to be aware of between Crohn's disease and ulcerative colitis. So in Crohn's disease, we have a disease that can affect anywhere from the mouth to anus, although it most commonly affects the terminal ileum, which is the last part of the small bowel, whereas ulcerative colitis, as you can see in the image on the bottom left, classically affects the rectum and then extends proximally along the large bowel. The way I remember it is ulcerative colitis, CO, therefore it is continuous, both start with CO, continuous disease. And therefore, by contrast, Crohn's disease has the skip lesions. The way I also remember it is you've got skip lesions, and therefore they're more likely to be sort of transmural, whereas continuous lesions only affecting the superficial layers because they sort of balance each other out, is how I remember it. Another thing that often comes out in SBAs is the effect of smoking on disease. So, interestingly, ulcerative colitis is one of the conditions where smoking is actually protective and can prevent flare ups. So, you may have patients who come in after having recently quit smoking and present with a flare up of ulcerative colitis, whereas in Crohn's disease, smoking does worsen disease activity. That being said, because smoking can be harmful in general, for so many other conditions, the advice is not, still to quit smoking if patients are able. So we've got one more question. We've got a few more questions for all of you. I'm sorry, we're not able to get the animations working. So what I'll do instead is read the questions out loud, and then I will show the answer with them after. So you've got a 32-year-old woman with known ulcerative colitis who presents with worsening diarrhea and abdominal pain. She reports passing blood-stained stools 8 times per day, and on examination, she is tachycardic and febrile. Blood tests show raised CRP and anemia. What is the most appropriate initial management? Rather than giving you all the options, what I will do is I will give you all a minute to think, and then we will go through the options together. Okay, so the answer is IV hydrocortisone. So if you remember, we talked about the way that we are managing a mild and moderate flare is different from how we would manage a severe flare up. And in this case, we would be managing um, it with IV hydrocortisone. Mesalazine is used for more mild, moderate disease, and in the case of such severe disease, particularly we've got blood-stained stool, opening the bowels 8 times a day, tachycardic, febrile. That meets the criteria for being classified as a severe flare-up, which means you need to be treated accordingly. Surgery, option D, we would reserve that normally for steroid refractory disease or for complications. And anti-motility agents like loperamide, option E, they're contraindicated because that can increase the risk of toxic megacolon. Oh, sorry, let me go back. So the next question, or since everyone can see it anyway, we'll go through it together. The next question, 28-year-old woman with Crohn's disease presents with worsening diarrhea and abdominal pain. She's recently completed a course of antibiotics for a UTI. Which investigation is most important to perform before escalating immunosuppressive therapy? So the answer is option C, stool culture and C. diff testing. The reason for that is because Although this patient has presented with what sounds like it could be a possible flare-up of inflammatory bowel disease, we do also need to rule out other conditions such as C. diff, particularly because we know the risk of C. diff is higher in patients who've recently completed a course of antibiotics. And what we don't want to do is treat this patient with immunosuppressives, particularly steroids or biologics, and which can actually make infectious causes of the diarrhea like C. diff even worse. I've got one more question. You've got a 24-year-old man who presents with a 3-month history of diarrhea and abdominal pain. He reports weight loss and perianal discomfort. The colonoscopy shows patchy areas of inflammation with intervening normal mucosa, and biopsies demonstrate transmural inflammation. What additional feature is most likely to be present? Do you think it's A, continuous inflammation from the rectum proximally? B, crypt abscesses confined to the mucosa. C, cobblestone appearance of the bowel. D, toxic megacolon. Or E, primary sclerosing cholangitis. So move to the next slide. The answer is C, cobblestone appearance of the bowel. And that's what we can see in this image of the endoscopy here. So going back to the question stem, we've got 3-month history of diarrhea, abdominal pain, weight loss, perianal discomfort. We've got patchy areas of inflammation with intervening normal mucosa. So that's suggested of skip lesions. And we've also got transmural inflammation. So all of this combined suggests that this patient has Crohn's disease. And cobblestone appearance of the bowel is classic in Crohn's disease. Options A, B, D, and E. So the continuous inflammation, the crypt abscesses, toxic megacolon, and primary sclerosing cholangitis, those are all also associated with inflammatory bowel disease, but they are associated with ulcerative colitis, not Crohn's disease specifically. So in summary, if you have a patient who's coming to you presenting with chronic diarrhea plus or minus blood or mucus, they may have systemic symptoms like weight loss, fatigue, nocturnal symptoms, then consider a diagnosis of IBD and investigate accordingly. Don't forget to think about the extraintestinal manifestations. Sometimes those can help point you in the direction of inflammatory bowel disease as well. And we covered the different types of treatment options that you've got, including the aminosalicylates, steroids, azathioprine and mercaptopurine, biologics, and surgery. Okay, now we've got 2 more questions, which I will again just read out loud before we move on. Sorry that the animations aren't working. So question 6 is, we've got a 26-year-old woman who presents with a 1-year history of intermittent abdominal pain, which is associated with bloating and altered bowel habit. The pain improves after opening her bowels. She has no weight loss, no rectal bleeding, and no nocturnal symptoms. And examination and blood tests, including full blood count, CRP, and coeliac screen, are normal. What is the most appropriate next step? Is it to do a colonoscopy? Is it to do a CT abdomen? Is it to do a fecal calprotectin? Is it to reassure and diagnose the patient as having IBS? Or is it to do a stool culture? Okay, I'll give everyone 10 more seconds to have a think. Okay, so the correct answer in this case was option D, to reassure and diagnose IBS. So in this case, we've got quite a young woman who's got intermittent abdominal pain and bloating with altered bowel habit for the past year, and pain specifically improves after opening her bowels. She doesn't report any systemic symptoms, so no weight loss, no rectal bleeding, no nocturnal symptoms. And we've done the necessary investigations to look for things like inflammation, race CRP. We've ruled out microcytic anemia. We've ruled out celiac disease. They've all come back normal. You may also, if you were worried, wish to have done a full blood, a fecal calprotectin, but in this case, the patient's history doesn't sound particularly like that anyhow. So what we can do is reassure and diagnose the patient as having IBS. IBS is a condition that we will be talking about next. And it's defined as having 6 or more months of abdominal pain. Patients may have an altered bowel habit, so they can come as constipation, diarrhea, mixed, with both constipation and diarrhea alternating. And patients may also have bloating. What's important is that they won't have any red flag symptoms, which I will come on to in my next slide. IBS is a diagnosis of exclusion. So what we need to do is rule out other sinister causes for patient's symptoms, whether that's bowel cancer, IBD, celiac disease, etc., depending on how they present. And it is a fairly common condition affecting up to 1 in 5 people. We don't know exactly what causes it, but we do know it's related to the gut-brain axis and increased sensitivity of the viscera, and often we feel it's believed that it's also related to changes in the gut microbiome and also impaired gut motility. So what are these red flag symptoms that we need to rule out in patients? These are the main ones specifically for lower GI conditions. So if you have a patient presenting with any of these red flag symptoms, that is a big sign that you perhaps need to explore further and may need to consider more serious causes of disease compared to patients who don't have these red flags. So if you have a patient presenting with rectal bleeding, weight loss, particularly if it's unexpected, if they're greater than 50 years old, or if they've got a family history of bowel conditions such as inflammatory bowel disease, celiac disease, bowel or ovarian cancer, if the patients present with an abdominal or rectal mass which is palpable, or they're significantly tender around their abdomen, if the patients have iron deficiency anemia, or they may have clinical signs of bowel cancer, inflammatory bowel disease, which are those extraintestinal manifestations of disease that we talked about earlier. These are all signs, big red flag symptoms to be aware of, and an indication that you need to do further investigations for the patient, and you can't simply rule it as IBS. So how do we investigate for IBS, and how do we make that diagnosis? This is a diagnosis that GPs can often make if they've done the investigations in the community. What we need to do is do blood tests, full blood count to look for microcytic anemia, CRP to look for inflammation, thyroid function tests because hyperthyroidism is associated with diarrhea, hypothyroidism is associated with constipation, and so we need to rule out dysfunctions of the thyroid which are causing the bowel symptoms. Anti-TTG and IgA are to check for celiac disease, and CA125 is a blood test that we use to check for ovarian cancer. It's one of the tumor markers for ovarian cancer. And the reason why we need to check for that is because oftentimes with ovarian cancer, patients may present with symptoms such as bloating, quite vague symptoms. So oftentimes we need, it can overlap with the symptoms that patients might have for a suspected IBS. And iron studies as well links on with the full blood count and looking for anemia. You may also wish to do stool tests. So the FIT test is to look for blood in their stool, which can be suggestive of bowel cancer. The fecal calprotectin is a marker that would be raised in IBD, inflammatory bowel disease. Stool MCNS would be abnormal and may grow a specific organism if the patient had an infective gastroenteritis, for example. And H. pylori is another cause of, bowel symptoms that we need to check for. If all of these if these investigations that we do are negative, then we can oftentimes diagnose, in fact, irritable bowel syndrome within the community. So how do we manage irritable bowel syndrome? Management can be divided into 2 different sections. The first section is lifestyle management and how patients can try and manage the disease without medications. Studies have shown that regular exercise, improving sleep, reducing stress levels, and regulating the mood can actually have a really big impact on symptoms of IBS. In addition to that, making changes to the diet. So the FODMAP diet, having regular small meals, reducing spicy or sort of fatty food intake, and drinking more water, and also trying to cut down on caffeine and carbonated drinks. I've got the next slide, which will go into a bit more detail on the FODMAP diet. in terms of how we manage it with medical, the medical options for managing IBS symptoms, it depends on the type of IBS they've got. So if the patient has IBS which tends more towards constipation, they may benefit from laxatives. If they have IBS which tends more towards diarrhea, they may benefit from antimotility agents like loperamide. And if patients are struggling with abdominal pain and cramping, then you may consider the use of antispasmodics, whether that's things like mebeverin and hyoscine butyl bromide, or even peppermint oil, or even drinking peppermint tea at home, we do know helps. And of course, you've also got IBS-specific cognitive behavioral therapy, which sometimes can be offered to help patients, and that can help sort of manage stress, their mood, and sleep, which does have a benefit to their symptoms as well. So on this next slide, you can see here what we call the low FODMAP diet, and this is the diet that patients with IBS should be trying to have to sort of manage their symptoms. So essentially, the foods that they're trying to avoid are things like garlic, beans, onions, specific fruits, proteins, fats, and vegetables. And what you want to do is avoid heavy gluten-based breads, muffins, particular fruits and vegetables like avocados, watermelon, peaches, in addition to avoiding sort of fatty foods and super processed or spicy foods, which can aggravate symptoms further. So we've got one more SBA from myself, and then we'll hand over to Olivia. I'm just going to read it out loud again, and then we'll move to the slide to reveal the answer. So question 7, we've got a 34-year-old man with a no previous diagnosis of IBS, and he presents with ongoing abdominal pain and bloating despite reassurance. His predominant symptom is diarrhea. Which management option is most appropriate to try first? I'll give everyone a minute to think, then I will reveal the options, and then we'll reveal the answer. Okay, so if you were given the choice between oral corticosteroids, loperamide, mesalazine, azathioprine, and a colonoscopy, what are you going to choose? And the answer is to give loperamide. So the reason is this patient's present with this got a known diagnosis of IBS and ongoing symptoms of his IBS. We know his predominant symptom is diarrhea, so what he would most benefit from is an anti-motility agent, and we know loperamide is the first-line management option for IBS, which has a tendency towards diarrhea. Oral corticosteroids, azathioprine, and colonoscopy are all sort of oral corticosteroids, mesalazine, and azathioprine are oral management options for inflammatory bowel disease, but aren't used for IBS. And colonoscopy isn't necessary at this point unless the patient were to have a change in their symptoms or present with red flag symptoms. Okay, now I'm going to hand over to Olivia to talk about the next half of our session.
Can you guys hear me okay?
Yes.
Cool. Yeah, so thanks, Rachel. The second half is essentially about the presentation of loose stool, diarrhea. We're going to cover celiac disease, gastroenteritis, and then a little bit on nutritional deficiencies. We'll try and keep it quite high yield, and I'll try not to run over for time. But obviously, look into other conditions. So another high yield condition would be your ischemic-related colitis, your mesenteric conditions, which will likely be covered by our surgical Mind the Bleep webinars. So check those out as well. So again, apologies for the lack of animation. I will just read the question before we talk about the answer. So our first question for this half is, you have a 22-year-old lady with type 1 diabetes, and she's presenting with ongoing loose stools and abdominal bloating. So you do an anti-TTG, and they're markedly raised. So you're suspecting a diagnosis of celiac disease, which we will talk about in a bit. The question is, which one of the following factors would increase the likelihood of a false negative serology test? So the options are hyposplenism, being on a gluten-free diet for 1 week prior to the test. Third option is a course of prednisolone 1 week prior to the test. Option D is the presence of dermatitis herpetiformis. And option E is a selective IgA deficiency. And that's quite a hefty question, so I'll just give you a little bit of time. Okay, so I guess this one is quite hard when you don't have the answers in front of you, but the answer in this case is the selective IgA deficiency. So this is really common in patients with celiac disease, and it's again one of the reasons why when you're doing your investigations, you need to be also checking your IgA levels. But we'll go into that now. The reason why the other ones are not right is firstly, hyposplenism isn't associated with celiac disease. Um, it's actually, well, it is, but it's a consequence, it's not a cause. And then being on a gluten free diet. So, obviously, we want our patients to be on gluten before we do investigations, but it would have to be around 6 months before your serology would turn negative. And then C, we're thinking about corticosteroids, immune modulating drugs, and these can contribute to a false negative test. But again, with the time frame here being 1 week, it's unlikely this would have an effect. And dermatitis herpetiformis is an inflammatory disease of the skin that's very associated with celiac disease. So it wouldn't be likely to cause a false negative test. So looking at celiac disease, so as I'm sure a lot of you know, it is caused by sensitivity to gluten, which is the protein found in your wheat, your barley, rye, and all your other kind of grains. And it's repeated exposure to this gluten that leads to your villi in your intestine becoming atrophied, so essentially becoming quite flat. And that in turn will cause malabsorption and associated features from that malabsorption. So, as we mentioned, malabsorption is kind of the hallmark of celiac disease, and that can present with things as you'd expect if you're not absorbing the right nutrients. So that can be tiredness, fatigue, failure to grow or put on weight. You can get anemias or any other kind of deficiencies from your failure to absorb things. And then, of course, as our MCQ presented, you can get very persistent abdominal symptoms. So, diarrhea or loose stool and bloating as examples. So, in addition to those features, we have some specific associations, and these quite often come up in your exam questions. They're quite high yield. So, your first one on the slide is your dermatitis herpetiformis. And as mentioned, that's an itchy vesicular skin eruption that is very closely related to celiac disease. And then similarly, we've got type 1 diabetes and thyroid disease up there because we've got a very strong association with autoimmune disorders. So things like thyroid problems, autoimmune hepatitis, these can all kind of present, or the patient might have those, and then you'll be suspecting celiac disease in the context of other symptoms such as diarrhea. And then these genes can also come up in exam questions. So celiac disease is very strongly associated with HLA, so human leukocyte antigen, DQ2 and DQ3. Around 95% of patients for DQ2, and I think that should be DR3 is a bit less associated. So diagnosis is made by a combination of your immunology and your small bowel biopsy, with duodenal biopsy being your gold standard. And all patients with positive serology, you need to refer onwards to your gastroenterologist for a biopsy. And as we alluded to in our MCQ, patients should be on a gluten diet. So if they're already taking a gluten-free diet, then you need to ask them to reintroduce it for at least 6 weeks prior to you doing your testing. So specifically talking about your immunology tests, your first line will be IgA antibodies against TTG. But then, as I mentioned, your total IgA must also be measured because a small proportion of these patients are IgA deficient, and that would give you a false negative um, measurement. So, in that situation, you can do an endomysial antibody, IgA, if your anti-TTG is weakly positive, and if they are IgA deficient, I should say, then you should do IgA antibodies, IgG antibodies. So I've highlighted in the corner your biopsy findings because, again, very high yield often comes up kind of differentiating between what Rachel talks about with your IBD findings and then celiac disease. So those four features, your villus atrophy, your crypt hyperplasia, the lymphocytes, and infiltration, those are the key features you need to kind of get in your brain, especially for exam MCQs. And then management is your gluten-free diet, which obviously removing the trigger. And interestingly, the villus atrophy and the immunology normally reverses once you're on a gluten-free diet for a while. And then we talked about malabsorption. So think about supplementation. So patients receiving calcium, vitamin D, or iron if their diet is insufficient. And again, related to that, it's really important to get input from your dietitian and your nutrition team if you have it at your hospital. And then patients can have functional hyposplenism. So celiac patients are at risk of your encapsulated infections. So a really important one is your pneumococcal vaccines. So they should definitely be offered that. And that's a boost every 5 years. And then influenza is offered on an individual basis. In the interest of time, I'm not going to talk too much about the complications, but we will briefly touch upon that when we go over malabsorption. So the next question, we're moving slightly away from celiac disease to gastroenteritis. And this question is, which one of the following is the most likely presentation of Staphylococcus aureus food poisoning? So option A is tenesmus, B is watery diarrhea, C is dysentery, D severe vomiting, or E presentation 24 to 48 hours after eating the affected food. Again, apologies because I know it's a lot harder when you can't see the question in front of you. And just give you a minute to think about it. So I've made a slide with your histories, high yield information, which we'll go through. But here we're talking about a pattern of illness related to acute food poisoning, and that essentially describes a sudden onset of nausea, vomiting, diarrhea after the ingestion of the toxin. And acute food poisoning is typically caused by Staph aureus, but then also Bacillus cereus or C. perfringens. So again, this is quite a busy slide with a lot of information, but I've tried to highlight the kind of key buzzwords and things to look out for in red. And then another thing I wanted to mention is the difference between secretory diarrhea and inflammatory diarrhea. So that can also affect how a loose stool would present. So cholera, Bacillus cereus, and Staph aureus are secretory diarrheas just because of the toxin causing shifts in water and electrolytes, and that's what gives you a watery diarrhea. And then things like Salmonella, Shigella, Campylobacter, they cause damage to the mucosa itself in the colon. So that is what gives you the bloody stools, fever, more of a systemic kind of illness. So just take a moment, kind of read through the slides. If you have any questions, put them in the chat or the comments. But yeah, just really important to think about complications and those key features that differentiate, because loose stool is common to all of them, but then some of them will have differentiating features, especially with incubation periods, which I've just put in the corner there, with some having quite a short incubation period, so your Staph aureus and your bacillus happening quite soon after ingesting toxins, and then later down the line is more like your Shigella and your atypical ones like amoebiasis. The other thing I was going to say is, of course, your viral causes, which I haven't really put on the slide, but things would be norovirus, rotavirus, adenovirus, which are common in hospitals. And then briefly for management, again, I haven't put it on the slide because I think it's quite self-explanatory in the sense that if your gastroenteritis is very mild or moderate, you don't really need investigation. We just obviously want to practice good infection control and hygiene, and most bacterial gastroenteritis is self-limiting. If things are severe, so if someone's very dehydrated, we'll provide fluids, and you can consider antibiotics depending on the individual circumstance. Complications, as you said, dehydration. There are specific complications. So Guillain-Barré is associated with Campylobacter. Again, that can come up in exams. And that's also, Campylobacter is also associated with reactive arthritis. The other one is with E. coli, which is your hemolytic uremic syndrome. Apologies, I can't go into these in too much detail in the interest of time, but again, if you have any questions, let me know. So similarly, still on the topic of diarrhea, of course, the next question is, you are on a ward round, you're reviewing a 71-year-old man. He initially presented with abdominal pain, diarrhea, and he's tested positive for C. diff. He was initially commenced on oral vancomycin, but after an extended course, his symptoms are still persisting. So I guess have a think about your second line management just for a bit, and then I'll give you some options. Okay, so he's had oral vancomycin. What would be your next appropriate step in management? First option is IV vancomycin with oral metronidazole. Second option is oral vancomycin, but you've added on some IV metronidazole. C is oral fidaxomicin. D, oral metronidazole. E, oral vancomycin with oral metronidazole. Again, it's hard when they're not in front of you. But think about what drug you'd like to give and whether you'd like it to be oral, IV, and if you'd like any additional antibiotics with it. So the answer in this situation is oral fidaxomicin. This is your second line for C. diff. So C. diff is a gram-positive bacteria, and that produces toxins that cause the diarrhea and inflammation when it colonizes the patient. Infection normally occurs when your normal bacterial flora has become disturbed, for example, with antibiotic use, especially your broad spectrum antibiotics. And as a result, C. diff is then able to multiply and colonize the colon. So risk factors, as you said, are antibiotic use, specifically clindamycin, your broad specs and cephalosporins, and then anything that increases your immunodeficiency. So it could be medication, could be malignancy, increasing age, PPIs as well. You need to be careful because they also increase your risk. And then being in hospital, because obviously things spread when you're in hospital and you're in a vulnerable state. Features are obviously diarrhea and then come with abdominal pain, raised cells on your full blood count. There's essentially quite a wide clinical spectrum of the infection, so it can be very mild diarrhea, and it can go all the way to life-threatening inflammation of the colon and systemic illness with that. And there are serious complications. So dehydration itself can be serious. A patient can go into shock, and toxic megacolon, which can lead to perforation. So if you're suspecting toxic megacolon, you need to escalate that very quickly, and you need to be giving IV fluids, IV hydrocortisone, um, and in C. diff, failure to respond to your IV steroids with that complication is an indication for surgery. So it can really progress quite badly in certain patients. Management for all patients, as you said, is to correct any losses, electrolytes, all the normal things we would do, which is good infection control. Put them in the side room, barrier nursing, and good hand hygiene. And then antibiotics. Your first episode will be vancomycin oral. And the reason we give it oral is because vancomycin has a low bioavailability when it's oral, and that means it stays in the stomach, so it targets where we want it to target. If a patient has a further episode, as in our MCQ, the next choice would be for dexamycin, again oral. And if the infection is severe, we would add on IV metronidazole to your oral vancomycin. Okay. To finish off, we will just cover malabsorption and some nutrient deficiencies. So this question, I guess it needs the pictures. I'm just going to put it on the screen. I'm sorry the answer is on there already. But we have a 45-year-old man presenting with a history of diarrhea, dermatitis, and cognitive impairment. You notice the lesions are primarily in sun-exposed areas, and you also notice this rash on his neck. So the question was, which underlying nutritional deficiency would you suspect? And in this case, it is vitamin B3, and that's also known as pellagra. So this is commonly seen in alcoholics and patients with eating disorders, and it's characterized by the 4 Ds, as I remember it. So diarrhea, dermatitis, dementia, and then death is the fatal one, if it's really bad. So this brown kind of scaly rash is called a casal necklace, and this is specifically on the neck. So the slides have just gone a bit wonky, but malabsorption is one of the MLA presentations that I think is really good to cover, and it's an umbrella term for medical conditions that are impairing your ability to absorb nutrients from your food, and that can lead to malnutrition, which can lead to complications. So, how do patients present? They characteristically have diarrhea, weight loss, similar to what we talked about earlier. It's if you're not absorbing nutrients, you're gonna have a weaker immune system, you're gonna have failure to growth, to put on weight, just feel quite weak, quite tired, and then with specific complications and presentations, which we'll go into to finish off. But I guess characterizing malabsorption is useful. So there are 2 ways you can characterize it. You can do it by where it's affecting, so intestinal, pancreatic, and biliary, because all those things are needed for your digestion. If we think back, to A-level biology. And the other way, which I think is a bit simpler, is classifying by primary or secondary causes. So primary, an example would be biliary atresia, and secondary might be an inflammatory disorder like celiac disease or IBD, which we touched upon, or other things such as cystic fibrosis, pancreatitis, or any surgery or radiotherapy that might have affected or removed part of the bowel. So general malabsorption of all nutrients is one way patients can present. And then some patients, depending on what the underlying cause is, will have particular difficulties absorbing fats, for example, proteins, bile acids, or carbohydrates. Again, just depending on what the underlying pathology is. So, specific deficiencies, I think this is just quite a nice table, thinking about how patients can present alongside the general symptoms of, fatigue, weight loss. There are some specific ones. So we've talked about the pellagra, which is your B3 deficiency, and then iron. Obviously, you can get an iron deficiency anemia and all the associated features. You'd be looking out for in your OSCE or in that stem of the question. And I think if you're ever not sure, just think back to what do these things actually do. So think about vitamin D, it's used for bones. If you're not absorbing it, you're going to have higher susceptibility to fractures, bone pain. Similarly, vitamin K is an important factor in clotting. So if you're not absorbing, it's going to lead to increased risk of bruising and bleeding. I'll just give you a moment to look over that slide and think of any other questions you might have for us before we just briefly go over a slide with a feedback form, and then we'll have a final 2 questions. We do have 2 more questions that Rachel has kindly put together, but if you wouldn't mind filling out the feedback, it would be really helpful for us, so we can improve the session. And hopefully next session we will work on the animation so the answers are a bit more mysterious.
Yes, sorry for the issue with the animations, everyone. We'll definitely get that sorted before next session. For the next USBs, what I'll probably do is I'll put them on the screen and I just suggest put a piece of paper or use your hand to cover the options. And then I can read those out, but that way you can have the question up for you. But we'd really value your feedback. Let us know what you liked about the session, what you think we could do better, and any other sessions that you'd like to see. We do read all your feedback, and it really does make a difference in helping us improve the sessions that we run for all of you. Just give everyone 20 more seconds to scan the form, or you can go via the link, and then we'll move on to our final 2 SBAs. Okay, so we've got an SBA coming up. Again, what I'll do is I'll put the question up so everyone can see it, and I'll read it out loud as well. What I suggest is just grab a piece of paper, or you can use your phone to cover up the answer, so you don't see it. And of course, for our next session, we'll get this sorted so the answer isn't revealed. Sorry, everyone. So we've got a 27-year-old woman, presents with chronic diarrhea, bloating, and fatigue. Her blood test shows iron deficiency anemia, and she has no weight loss and no rectal bleeding. Which investigation is most appropriate to request first? Is it A, a duodenal biopsy? Is it B, tissue transglutaminase IgA? Is it C, fecal calprotectin? D, colonoscopy? Or E, hydrogen breath test? Give everyone 20 seconds to have a think. Okay, so the correct answer is B, tissue transglutaminase IgA. So the reason for this is that what this question is asking for is the most appropriate investigation to request first. All of these investigations are valid options, but what this woman's symptoms are most suggestive of are celiac disease, the first line investigation being anti-TTG and IgA. duodenal biopsy, that is the sort of one of the investigations that we can do for bowel conditions, including inflammatory bowel disease. Same with fecal calprotectin is for inflammatory bowel disease. Colonoscopy is very invasive, and so it's not often a first-line investigation unless you're suspecting something very sinister, like a 2-week wait pathway colonoscopy for suspected bowel cancer. And the hydrogen breath test is if you were suspecting small intestinal bacterial overgrowth syndrome. But again, in this case, um, you know, when you're thinking about when patients come, try and think about the most common conditions and the most likely diagnoses, and that can often point you towards the best first line investigations to do. And then that can point you, of course, if you need to do further investigations after that, then that can be done. Okay, we've got one more question. Again, I'm going to bring the question up on the screen and then just use a piece of paper or your hand to cover up the options if you'd like. So we've got a 58-year-old man presents to his GP with 3 months of looser stools and increased stool frequency. He reports unintentional weight loss and intermittent rectal bleeding. He has no previous bowel disease and examination is unremarkable. What is the most appropriate next step? A. Fecal calprotectin. B. A trial of antispasmodics. C. To reassure and review in 6 weeks. D. An urgent 2-week wait colorectal referral. Or E. A stool culture. Again, I'll give everyone a couple of seconds to have a think. Okay, so the correct answer is D. An urgent 2-week wait colorectal referral. The reason for that is we've got a man who's over the age of 50 reporting a change in his bowel habit, weight loss, as well as intermittent rectal bleeding. Those are all, those are red flag bowel symptoms that need to be taken seriously. And while it may not be bowel cancer, it's important that we rule it out by sending the 2-week wait referral to under the suspected colorectal cancer pathway. What this typically involves is the patient undergoing a colonoscopy, and if, of course, the colonoscopy comes back clear and we're not suspecting bowel cancer, then of course we can explore other other causes for his symptoms. But the most important symptom, and therefore the most important condition to rule out, and there is bowel cancer, and therefore the most appropriate next step is to refer him under the 2-week wait pathway. Okay, thank you very much, everyone, for attending our session today. If you enjoyed today, or if you'd like to learn more about gastroenterology and prepare for the UKMLA, please do consider signing up for our next session, which is on upper GI disease. It will be taking place, sorry, that's a typo, it's not the 7th of January. It will be taking place in February. And you can scan this QR code to sign up for the webinar again. It will be hosted similarly today via YouTube sort of live stream. And of course, thank you everyone for your patience with the technical issues we've had today. We'll make sure to get that sorted before our next session. So please scan the QR code if you are interested in joining our next session. It will be taking place on the 9th of February. So that's the 9th of February, which is a Monday, again from 7 to 8 p.m. Okay, so that brings us to the end of our session. If anyone has any questions, feel free to leave them in the chat, and we'll answer them as best as we can. Thank you very much, everyone, for attending, and hope you have a lovely rest of your evening. Okay, doesn't seem like there are any questions, so we'll leave the webinar there. Hope to see you guys in some of our future sessions. Have a nice night, everyone.